Welcome to What Works. My name is Sidsel Roalkvam. I'm a director at the Center for Development and the Environment at the University of Oslo. And I'm here to talk to you about what works in global health. That has been my research area for many, many years. It is hard to imagine a more effective method than vaccination for keeping children healthy. Not only do vaccines save lives in huge numbers, they are also cost-effective, relatively easy to deliver. In most cases, they provide lifelong protection. I am going to talk about some of its successes, focused on the World Health Organization and its extended immunization program, and a successful country response to it. The World Health Organization established the expanded program on immunization, also called the EPI, in 1974 to increase the uptake of routine childhood vaccines across the world. This program was one of WHO's great successes. Coverage rates of EPI vaccines climbed rapidly from less than 5% to over 80% in many low and middle-income countries. By the 1980s, coverage with EPI vaccines in the global south was similar to, or even better, than what was achieved in many parts of the global north, where the infectious diseases are not any longer seen as a significant threat. But vaccination is not only easy. Vaccination requires high levels of coverage. When enough people are immunized within a given community, disease cannot spread. Measles, for example, require 95% coverage to provide this benefit. The recommendation for most other childhood vaccines is 80 to 85%. The health benefits of immunization, therefore, are to a large degree dependent on achieving relatively high coverage among cohort after cohort of children. For this to happen, EPI developed an immunization system structure, and I'm going to talk to you a bit about that. Firstly, national immunization programs can only function when specific set of inputs, vaccines, are available on reliable basis. Many vaccines require multiple doses for maximum effectiveness. An EPI developed vaccine schedule to achieve effectiveness using required and recommended vaccines while minimizing the number of healthcare systems interactions. Secondly, all vaccines are thermally unstable. Closed-wall vaccines need to be stored in fridges, cages, and boxes that can maintain a stable temperature. To ensure this, the EPI developed cold chain management routines. The cold chain is the spine of any immunization system. The cold chain is a concrete chain of immunization depots, buildings, refrigerators, freezers, coolers, and diesel aggregates that branch out from the national, regional to local communities where the actual vaccination takes place. These can be fixed immunization points or door-to-door immunization services. Thirdly, at the periphery of the cold chain, vaccines are distributed to small clinics in insulated coolers and packed in dry ice. When vaccine failure is detected, the cause is often to be found in the breakage of the cold chain, a power cut, a breakdown of a car, a road over-flooded. The further out in the periphery of the cold chain you come, the more vulnerable the cold chain. Lastly, individual vaccines needs to reach each and every child in relation to each child's individual vaccine schedule, dependent on the date of birth. To ensure this, the EPI developed a vaccination card or the health card where the schedule for each individual child is stipulated. They educated a new cadre of health workers specifically trained for vaccine services to manage this card and to manage the injections. In its simplicity, then, the immunization system is also quite complex. And there is still great variation in coverage between countries and within countries as countries grapple with donor dependencies and tough priorities within weak health systems. Also, and importantly, immunization is preventive medicine, and in countries where disease burden is high, there is active and political demand for curative treatment. Malawi is a puzzle, or a paradox in this regard. Let me start by giving you a few facts. UNDP has ranked Malawi 171 out of 181 countries on the Human Development Index. Life expectancy is only 54 years. HIV/AIDS prevalence is high, so is malnutrition, with a stunting rate as high as 40%. The health system is extremely weak, moving in and out of crisis as donors frequently hold back funds due to corruption charges. Human resources for health is desperately lacking, with a 74% vacancy of nurses. Access to health services is limited, as only 46% of the population live within 5 kilometers of a health facility. Despite its many challenges, Malawi has managed to sustain an impressive immunization coverage. In 2015, the government proudly reported in its Millennium Development Goals Endline report that they had made significant progress in reducing the child mortality rate, the under 5 mortality rate, indeed very close to the target set. The Malawian government attributed progress exactly to access to immunization. So what is it then Malawi has done? I shall argue it has managed to sustain its old EPI program. The Malawian Immunization Program was established in 1979 as part of the WHO EPI Program, then with the vision to keep Malawian children free from vaccine-preventable diseases. 10 years after the country attained the universal immunization goal, when it reached an average coverage of 80% and above for all antigens. Coverage continues to be sustained. When we asked the head of the EPI program in Malawi a few years back what could explain the Malawian success, she said, "We have worked with the communities so that communities actively demand vaccine services." So what does that mean? And what is it that the EPI officers then did? Firstly, they placed immunization within existing knowledge and perceptions of diseases. In communities where child mortality is high, protecting children becomes a major concern. Also, the identity of motherhood in Malawi, as in many other countries in the world, is intermittently tied to child protection. Secondly, the EPI officers sought the support of traditional chiefs. The traditional chiefs are crucial in Malawian governance and effective champions for local development. In the early days, immunization took place in the chief's yard and became by this what mothers and community members should do as citizens and as members of local communities in order to protect their children. They worked on developing trust in their provider by educating health surveillance assistants, HASs, a cadre of community health workers that links the formal health system with local communities. Their history reached back to the 1960s, when they were recruited as smallpox vaccinators. They are appointed by the chief, trusted by the community, and with generations of experience of immunization practices and child protection. And thirdly, trust and active demand depends upon the quality of vaccine delivery. In Malawi, immunization are delivered on a regular basis in fixed health units run by the government, old mission hospitals or private institutions. Hospitals and health centers organize outreach clinic. They have a cold chain that after years of experience work, even within meager resources. Lastly, but importantly, Malawian government and its health authorities take pride in the immunization system, its output and impact. There is strong political will to maintain it. Through different presidencies, the politicians has worked to protect it and sought support amongst the donors to secure its continuation. Even among the Malawian politicians, there is an active demand. Today, immunization is a global system. It concerns an impressive medical technology developed within a transnational industry, a global welfare system, in my talk represented by WHO, supporting the national government system, communities and families, in its attempt to fit a global immunization program to the local circumstances. Hence, responding to the concern so salient in every place, how are we to ensure health and growth of our infants and children?